Talking about, we're going to spend a whole lot of time talking about thoracic. We're going to not spend a whole lot of time about the abdominal side, but heavy on the thoracic. So away we go. Here's where we're going. We're going to review the mechanism of injuries for thoracic and abdominal trauma. We're going to review the patient assessments, something you can do about. We're going to review the treatments of thoracic and abdominal trauma, and we're going to get a little bit maybe into case studies. We'll see how much time we got. So, second leading cause of trauma death, ever head injury. So as you line up about trauma, the idea that head and chest play a part together. That is, very, very frequently, when you have somebody with head trauma, for whatever reason, they've got the mechanism that points towards the chest as well. And so you have to be highly suspicious, especially in the unconscious patient, that perhaps they got some things that's going to kill them. Causes somewhere around 20-25% mortality rate. Survival rate for traumatic arrest is somewhere around 3% for blood trauma. But check it out. Why is there a survival rate of 15-20% with penetrating trauma?
Localized?
But wouldn't you expect that if they got a bullet wound, wouldn't you expect that if they got a knife wound into their chest or abdomen, that their mortality rate is going to be higher?
No, it's localized in one spot.
Okay, that perhaps is the answer. What else about it?
Our pucker factor goes up.
There you go. So the idea that we're actually doing something, we can see it, we can actually do something about it. It's right there in our face. So that's part of it. Many deaths due to thoracic trauma are preventable, i.e. seatbelts, prevention of falls, etc., etc., etc. And majority of chest trauma doesn't require surgical intervention, which is a change, folks, which is a change from about 15 years ago to where a lot of these patients were going to surgery. Why are they not? How is that changing? There's actually a couple of different diagnostic tests in hospitals that have changed that. CAT scan is one of them. Ultrasound is the other. Ultrasound, CAT scanners are now, they're doing it automatically to see whether or not they can send other patients or having it taken to a surgical table where the risk is that much greater for them dying on the table. So catch this. Doug was talking yesterday about penetrating trauma. The idea is because that from an anatomical standpoint and from an injury standpoint, you don't know where abdomen leads off and where chest starts. The idea of the two should be considered together. That is, that if something happens to abdomen, you should automatically be thinking about the possibility of trauma to the chest as well. Especially with knife wounds, especially with penetrating trauma, you don't know the trajectory of the path. So to that, you have to consider one with the other, joined together. Penetrating trauma anteriorly, injuries to the heart should be assumed if entry points are anywhere between the two mid-clavicular lines. So what we're talking about is here will equal this and this right here. Okay? So anything in terms of injury here should equal this right here. So we've been through A&P of respiratory systems forever and ever, and you're going to do it again between now and tomorrow morning as well. So ventilation is a mechanical process of taking in and moving out air. You know that already. It requires an intact chest wall, requires nerve pathways, requires a diaphragm intact, and requires pleural cavity and brainstem. So to this point, you've been studying about what happens when we take a breath in, we exhale. We've been talking about what happens in the pulmonary circuit as far as crossing the alveolar line. But the idea that this has to be intact to work together is part of what we're talking about this afternoon. You should know at the end of exhalation, the atmospheric pressure is equal on the inside and outside. You should know that we breathe in somewhere around 500 mils. We've been through that already. And of that, about 150 is dead space. All right, we've been through this. I'm not going to hang out here. We've already been there. So what are impairments of ventilatory efficiency? That is, when somebody has chest trauma, what are some impairments for them to be able to ventilate and have a respiratory effect? Well, you gotta have a good excursion. So anytime you have pain within the chest, such as pneumo perhaps, yep. What else?
Barotrauma?
Yeah, and we're talking about non-trauma, MI. What was that?
Barotrauma?
Barotrauma, if you have somebody with a COPD. How about a simple thing like a broken rib? Is a broken rib going to have a problem in terms of somebody taking a deep breath in?
Yeah.
Okay? Hurts like so, right? The idea in terms of pain is going to have a bearing as to how well your patients are breathing. How about air in the pleural space, such as a pneumothorax, such as a hemothorax, all possibilities. How about asymmetrical movements, such as what? As a flail chest, it's going to create that, right? Bleeding into the pleural space, pneumothorax, ineffective diaphragm contraction. Why? So you can have neurogenic type shock. You can also have direct issues with the diaphragm itself. So you've seen this now. This is about the fourth time you've seen it. You didn't fare so well last week when I asked you about it. So tell me about thick principle, because that's what this is.
Fracture-inspired oxygen, or oxygen, is what the blood cells actually have on them, correct?
Yep. So FiO2 is concentration that you and I are breathing right now. If we were in an enclosed spot to where carbon monoxide was the name of the game this afternoon, will we be breathing in 21%? Nope. So confined space is a good way of thinking about inspired oxygen or concentration. Probate movement of oxygen across the alveolar capillary membrane into arterial bloodstream. What are we talking about there? What's the problem? So from a trauma standpoint, we're talking about a PE. Yeah, you're right in terms of medical thing as far as COPD, CHF, the like up. But in terms of a trauma type thing, a pneumothorax or a PE would be the thing we're talking about here. That is that the pulmonary artery can't pump forward, it's just going to sit there. We're not going to oxygenate, we're not going to dump off CO2, it's just going to sit there. Adequate number of RBCs to carry oxygen. What are we talking about, folks? Yeah. So how about a little bit of anemia? How about sickle cell anemia that would be part of that problem? Proper tissue perfusion is about shock. Efficient offloading of oxygen at tissue level is about shock. So again, this is about the 14th time you've had this, and you can be certain that you'll see it again. So make sure that you somehow put it fixed into your thinking process for it. So there's a fatal triad trauma. You've seen this now. This is about the fourth time you've seen this, in one form or another. You saw it again this morning. So probably comes the idea that it's important for somebody, and so make sure that you bring your two members back. Come on, guys, you should have this already. 14 times into this. So with these three, when hypothermia happens, it's going to decrease the platelet activation and adhesion. It's going to increase the metabolic rate. Your patients are going to end up as being hypoglycemic, in part because of this right here. Your patients are going to end up with trauma that gets worse and worse and worse based on the hypothermia. Do you have an effect? Can you have an effect in terms of hypothermia? Yes. Absolutely. You can do simple things about that, right? Acidosis. Which type of acidosis are we primarily talking about here? Metabolic, right? Because we're talking about bleeding, we're talking about blood loss. Inhibits the clotting factor functions, which is a problem. It's going to create a problem in terms of hyperperfusion of the tissues, which goes back to thick, previous slide. Acidosis directly plays a part in this. Coagulopathy, it has an issue in terms of clotting factors. So coagulopathy is going to lead to hypothermia. Can we do things in terms of coagulopathy? Can we have an effect on that? Right? So we're treating it for shock along the way. We're doing the smart things along the way to get to where they need to be. All this results in this. So when I ask you about secondary injury, when I ask you about a continuing lift, hypoxia, hypercarbia, hypotension, hyperkalemia, rhabdomyolysis. We don't cure rhabdomyolysis, and especially in the pre-hospital setting. But can we have a huge effect on the rest of this? Right? So that's all on us. That's something we can do something about. That's one of the other reasons that I like thoracic trauma is that we can get our hands around it. I'll show my mouth. I'll let you write.
What's the pulmonary VP? Ventilation perfusion?
Ventilatory perfusion, yes. So again, we're talking about blood coming back through that pulmonary artery and can't get to the lungs because of whatever's going on there. Pneumothorax is most probably.
Can we get these slides sent to us?
You should have it in.
They're not the same, so we're missing a lot of things.
You don't have this?
We have
There's
that
some
on
of
a
the-
different slide, but there's a lot of stuff different.
There's only like half the slides.
Yeah,
So
it's
the
like half
answer is
of
yes.
them.
Okay, I apologize. Hyperkalemia. How is it that we can prevent hyperkalemia? But you just gotta pull up bicarb just because they might have hyperkalemia? The answer is you can't prevent it, okay? Can you do things about it? Absolutely. Can you identify it and have a healthy degree of respect for it? Absolutely. That comes into cardiac monitoring. That comes into a number of different things along the way.
Those are 5 H's, 5 C's that they're always talking about.
No. So from a general pathophysiology, impairments to the cardiac output would include blood loss. Why? Yes, but why? Why in terms of cardiac output? So it has an effect on preload. So does it have an effect on Frank Starling? Remember Frank Starling? Not the guy Frank Starling. Yeah, but what was Frank Starling about? Is it about?
It's the total amount of volume pumped by the stretch receptor
Good.
on the return ventricles.
You're right there. So the idea, the more preload that's coming into the atria, that's flowing into the ventricle, means more contraction output. When you have a decreased cardiac output, is it going to have an effect in terms of Frank Starling? The ventricles can't pump out as much. Your patients are going to continue to be in hypovolemic shock because of that. So not only the preload, but it's this as well. Blood in the pericardial sac, pericardial tamponade. We'll talk about it in terms of what it is. You can have issues in terms of what penetrating trauma, the myocardial valve. You can have issues in terms of vascular disruption, such as a penetrating type trauma. You know this already, or should know this already. Great vessels of the arteries would include the aorta, the carotid, subclavian, intercostal, and external jugular. Veins would include superior, inferior vena cava. We've talked about this. Subclavian, internal jugular. Mediastinum, the area between the lungs. So this you should know, but this you should know already anyways. It should not be a surprise. Mediastinum would include the heart, the trachea, the vena cava, pulmonary artery, the aorta, the esophagus, and the lymph nodes. So this area is just like packed full of all this stuff that we're talking about. Huge, huge, huge in terms of things that can go wrong. So part of your assessment findings and checking that pulse, we've talked about this a couple different times, but you're checking it for rhythm, rate, and regularity. That is, if you are checking for a radial pulse and they have very, very thready type pulse that's irregular, should that be cause of concern in terms of what's going on with the cardiac output, right? The idea that tachycardia is a typical type thing, especially with trauma. But can an old guy like myself sustain a pulse of 180 for any length of time? Probably not. So the idea in terms of how tachycardic, how regular, gives you a clue in terms of how sick that your patient is. What does narrow pulse pressure indicate? What kind of shock? Nope. Narrow pulse pressure is early shock. Early shock. You can see the narrow pulse pressure. Okay. Yes, you can see it in terms of pericardial tamponade. Yes, you can see it in a number of different things. But in a perfect world, a narrow pulse pressure is about early onset of shock. What's a pulsus paradoxus? That's something we could question. Pulsus paradoxus.
Different pulses?
Kind of like?
Unequal pulses?
Kind of like?
Side to side.
You guys are guessing now.
Like different pulse pressure on each side.
Okay, that's part of it, but this is about pulsus paradoxus. It changes based on taking a deep breath. Okay? So your pulse changes based on taking a deep breath is about pulsus paradoxus. When might you have that condition? Oh, I don't know, significant chest trauma, you might feel a different pulse on one side versus the other, and it might change based on them taking a deep breath. It's about pulsus paradoxus.
In chest trauma?
Yes.
Probably a stupid question, but what about an anxiety?
I suppose it's possible. I haven't seen it. I haven't heard about it. Maybe.
So when you inhale, your pressure and pulses drop?
Yes. With a certain condition in terms of trauma.
That's different from orthostatic.
Yes.
It's a lot less than ortho, isn't it?
What do you mean?
Like, significance and change?
Yeah, it isn't, unless you literally have your hand on a radial pulse with this and you're monitoring this, you're not going to see it. And so it tends to be more of an academic type question, but it's still there in terms of possibility. So part of your assessment findings with the chest, naturally, is about what happens with respiration. Are they tachypnic? Are they bradypneic? Are they labored respiration? Retractions, any other evidence of respiratory distress goes along naturally with chest trauma. Skin signs. What's ecchymosis? Bruising. Okay, so again, put that into vocabulary. If you don't have that, put it into your vocabulary. You're going to start to see that on a regular basis. So naturally, with skin signs and chest trauma, abdominal trauma, you're looking for any bruising across the chest or abdomen. So as you check out the neck, you're looking for JVD. You're feeling for subcutaneous emphysema. We'll talk about that separately as we get into a little bit deeper with this. We're talking about whether or not there's a shift in the trachea. We're talking about any penetrating wounds into the neck, either that you see with a weapon or that has a hole in it in terms of gurgling around it. In terms of your assessment, includes contusions. What's a contusion? Blunt trauma, right? Blunt trauma to, in this case, the chest or abdomen, same. Any tenderness that your patient will tell you about. Asymmetrical chest rise that goes along with a little chest. Lung sounds, are they absent or decreased? Are they unilateral, that is on one side only? Are they bilateral? Where's the location that you hear those breath sounds? And whether or not you have vowel sounds in the chest. Why would you have vowel sounds in the chest? That ruptured diaphragm would be one of the classic signs about that. We'll talk about that separately as well. The roof of the bowel is up in the chest. That's kind of interesting.
This might be silly, but what's the difference between contusion and ecchymosis?
Ecchymosis is bruising. Contusion is just one trauma in general. So as we start talking about cardiology next month, we're going to talk about ST. We're going to talk about ST changes. But the idea, and especially with a shock to the chest, a shock to the heart, or a shock to anything around the heart, the idea there can be changes in terms of ST elevation. And so you have this patient that shows up and looks like a classic MI, when indeed what happened was they took a shot to the heart instead. By the history, you want to know if they're, you want to look at them as whether or not they're dyspneic. What's a way of kind of measuring that? Yeah. So speech dyspnea in terms of, are we talking about 1 to 2 word sentences, or are we talking about 5 to 6 word or complete sentences? Gives you a clue in terms of how severe this is. Other associated signs and symptoms might include pain, might include symptoms prior to the incident itself. What kind of medical history do they bring into this little puppy? Any past history of cardiorespiratory diseases that comes into this as well, for the same thing we talked about this morning with burns. The idea that you bring a bunch of issues into chest trauma is going to be just that much worse as far as taking care of them and managing. So as you talked about yesterday with blunt trauma, it can be a direct impact, can be a rapid deceleration, disruption type thing, so a coup type thing with the chest that involves the vessels, the lungs, the trachea, and so on, as far as all the different anatomical positions. And then finally compression, such as a crush or anaphylaxis, or not anaphylaxis, excuse me, asphyxia. The idea in terms of compression, give me an example of that.
Steering wheel.
Say again.
Steering
So
wheel.
steering wheel, good. You have something else?
Pinned under a car.
Yeah, there you go. That's a classic one right there in terms of being pinned under the car. So that would be an example of the asphyxia type thing, although there's other, and I'll kind of share that with you if we get involved in that. So, in terms of accidents, might include an MVC, might include falls, might include assault, or a bunch of other stuff. From penetrating, we talked about this yesterday afternoon, low versus medium versus high velocity. The idea in terms of what was the weapon of choice for the trauma that's going on. Rib fractures and chest wall contusions would be a sign of an underlying injury, would be an important thing for you to know. That is, you're feeling for a crepitus without the chest. How much energy went into whatever's underneath all that? Pneumothorax, contusion to the lung, goes on and on in terms of possibilities. Was there a sharp bone that further lacerated? Some other things along the way. You heard from Doug yesterday about this in terms of penetrating trauma. The idea that this temporary cavity or this permanent cavity, depending on the size of the bullet, creates issues as far as you not knowing exactly what part of the organ that's hit, how many different organs that it's hit, or what the vital things that's in between all that. So, what do you think? Sharp wound, yeah, you got it right. So, this was a guy who took a machete to the chest.
We just gave
That
That would be a nasty exception. So, what would you expect in terms of possibilities Where's this located in the body?
Your heart's right there.
So your heart is, it certainly looks deep enough to be, the heart is being disrupted. What else? Lungs, definitely. What else? Sternum, yeah. Depending on that, you could add a trachea. What else? Good. So you've got great vessels that could be part of this as well. The idea that you've got a sick patient that you're going to be taking care of. How are you going to treat this? You're just going to put your dry sterile dressing on this, right? So your chest seals are best case scenario. Your chest seals are only about like this.
Just keep slapping them on.
There you go. So the idea in terms of using some plastic packing that's going to be able to seal around this is your next best bet for something as big as what this is. So what else are you going to be dealing with in this guy? Definitely respiratory distress, definitely airway issues, definitely getting some IV started. How about hypothermia? This guy's going to chill off in a hurry. Yep. Guy on the left. So I would be thinking, you're right, I'd be thinking about a second chest wound. What else might you be thinking about? Liver? Say again, Kevin? Yep. So definitely a liver. Does he have a liver lack because of this, okay? Do we know how deep that is? Do we know what the pattern is in terms of the knife? Not so much. All bets are off. You could ding the top side of the right kidney based on where that knife went to as well. So you're into the retroperitoneal area, that space. What's your treatment? You still want to seal this, right? It's an open chest wound or open abdominal wound, depending on how you look at it. What else do you want to do with this guy? Yeah, probably in terms of transport, sitting him upright is probably going to be the best move. Are you going to C-spine this person? So check this out. I don't know if Doug mentioned this to you at all yesterday or not. But the number of times that you have to do spinal mobilization on somebody with penetrating trauma is minute. Did you know that? Minute. The idea that typically you do not have to do it unless there's outright evidence to something in terms of cervical spine. Otherwise, forego it and just get into what it needs to be. What about the guy on the right? Besides his tattoo taking a beating, what else is going on with this guy? Nope.
What was that? Somebody just went flashing like.
We don't know how deep those are, so the spinal cord is going to be affected.
Absolutely.
So definitely kidneys.
Spinal cord,
We have to
kidneys.
C-spine this guy.
I don't know.
Maybe, maybe not. What would you want to know about him before you see spinal?
What?
How about
Motor function.
There you go. How about neurodeficit, right?
Yeah.
Okay. What else is at risk in this guy?
Kidney?
Very good. So kidney on the right side. Okay. What else? Lung definitely on that right upper side. Again, you don't know how deep this is along the way here. What is created underneath all that? Okay. So again, energy and the womb. Yep. All right. So this is old school. I'll let you write and then we'll talk. This is kind of old school. I'm getting ready to talk with you about. So on the top, this used to be described as ways, PHTLS. This used to be described as 12 different ways that could kill you in terms of chest trauma. The first 6, the lethal 6, is things that you can have an effect on. The hidden 6 is the ones that either going to end up being dead unseen or the ones you're not necessarily going to be believing about, okay? You start having a thoracic aortic disruption, the idea they're going to bleed out in a matter of minutes prior to you getting it. There's an example of that. Whereas you look at the top 6, can we do something about airway obstruction? Can we do something about touching pneumothorax? Can we have an effect on cardiac tamponade? Not so much as we used to, but still. Can we do something about hemothorax? Not so much, but identifying for what it is and getting them to a place where they can have a chest tube and surgery.
There's only 5 on the notes.
1, 2, 3, 4. Yes.
It'll be on the test.
But I-
It's hidden.
You'll find it on the test.
Very good. Yeah, because I use it so much. Thank you very much.
But it's hidden. It's hidden. That's where you're gonna find it.
Extra credit. All right, so let me take a look. Thank you, I think. All right, so again, these are the ones that will kill your patient prior to you ever getting on scene, okay? These are something that you can have an effect on in terms of this. The reason I still continue to teach this, the reason I like this, is in this pea brain, it's a simple way of thinking about what effects you can have and what's going to be beyond your control. Such as this.
Diaphragm tear.
What is that?
Traumatic diaphragm.
Traumatic diaphragm tear. Did you hear that? Number 6. We'll talk about that.
Traumatic
Traumatic
diaphragm.
diaphragm.
So what are you going to do with this gentleman?
Airway.
Nothing gets lost in you. You guys are out to kill me slowly. What are you going to do with this guy? What's going on with him?
He's got knife in it.
Thank you very much. Again, clarify obvious. Come on.
He's got possible airway obstruction.
There you go. Let's start there. Do you know where the tip of this knife is at? Or how big it is? Or anything else like that, right? Do you know if this is kind of tapping off in terms of blood vessels within that? Or whether or not he's sitting there with a bunch of blood seeping up through his airway? I've had patients, not like this, but I've had patients to where whatever's going on in an airway, they would just continue to bleed and bleed and bleed. And I filled up 1, 2, 3 suction catheters in terms of what's coming out of their airway. So it will happen to you, folks.
So Doug said never pull anything out, but the book says if it's obstruct in the thoracic and you
Yep.
have to do compressions.
Yep.
If you had to do compressions on this guy, that portion of the
Yep.
torso is going like this
Yep.
constantly.
I have to tell you that this is probably the exception where I would end up pulling that knife if I had an airway issue going on.
Or compressions.
Or needs to be, yeah. That's just a wee bit low for a Clyde, but still might be the only airway that you're able to get at this time.
If that was in the area of a cripe and still kind of breathing, maybe that kind of time would you probably pull it?
As a consideration, yeah. So when we talk about a tracheobronchial rupture, we're talking about something that's uncommon. So it has an effect in terms of trachea, it has an effect in terms of bronchial. So remember that the primary and secondary and tertiary type bronchi? We're talking here primarily the primary bronchi being the thing we're talking about. Less than 3% of the time happens most frequently with blood chest trauma. 80% occurs somewhere around the carotid. What's a carotid again? Tell me about that.
Why?
So it's that Y where it goes right and left as far as the bronchi, right? 75 to 80% is secondary to penetrating trauma. Those who survive to the ED, high mortality rate, greater than 30%. So getting them to the emergency department is only one part of it. The rest of it then becomes an issue in terms of being able to ventilate the patient. So with this, you might have fractures of the upper three ribs. Based on the mechanism, we're talking about blood trauma, we're talking about issues with the ribs. We start getting into pulmonary contusion based on that, and we'll kind of touch on that. We will get into that here in a couple minutes.
So is the rupture from the blunt trauma, or is it from the ribs, like getting?
So what they're saying is that it's not the three ribs. It's just the fact that this kind of goes along with whatever the blood trauma is. So not only are they taking damage to here, but they're taking it to here as well. Make sense?
So this is a tearing of the trachea off of the carina?
Check.
What is cervical trachea again?
Cervical trachea?
Yeah. So,
Oh, you're talking about right here. I'm sorry.
yeah, so isn't that the same area you're kind of?
Yeah. So
talking about
this
the
is just the
trachea bronchial?
posterior side. This is the posterior side to the trachea itself. Yeah.
Okay.
So pathophys on the tracheobronchial rupture is a rapid movement of air into the pleural space. Pneumothorax refractory, that is that you try to needle this chest and does not improve the condition, right? Be suspicious of this. You would have somebody with respiratory distress. You would have somebody that's dyspneic, tachypnic, obvious sub-Q emphysema. So let's time out and tell me about sub-Q emphysema. Again.
Does it sound like Rice Krispies, not wrapped on top under the?
So it's kind of like the bubble wrap type pop, right? Rice Krispie wrap is sometimes the way it's called as well. Where would you find it?
Or site.
Yeah, but not just around the site, Charlie.
It's gonna go, it's gonna just work
Under
its
the
way up.
skin.
So it's anything here. It's anything here up to the neck right here, okay? And so, again, you won't necessarily see it in terms of looking and saying, aha, that looks like sub-Q air, okay? You're going to have to feel the chest in terms of feeling the air pockets to it.
Are
Okay?
you gonna hear lung sounds with that?
Very, very decreased lung sounds.
All
And
throughout, or-
especially if you're already thinking, if you've already near this chest on it, you're thinking that there's nothing going on there.
That would be on both sides or just one side?
Maybe on both sides, depending on how big the leak is. So I don't care right now that you remember about Hammond's sign. We'll come back and talk about that later in life. The idea in terms of sub-Q air is what I want you to remember about this. When we talk about hemostasis, what is that about? Spitting up or coughing up blood, right? So if this person is able to, they're conscious, you're going to see them with bright red blood, sometimes massive amounts. What do you want to do about this person? High diesel. Perhaps think about needling the chest, although probably would not make a huge difference along the way. They need to be at a certain stable. So a simple thing like a rib fracture is a big deal. Most common chest wall injury from direct trauma. More common in adults than children. Although in children, what can you tell me about rib fractures?
It means it's reliable force in order to break that rib because of the pliability of the bone.
So if indeed there's crepitus with a child, you know that's massive trauma, right? So what about if you feel for the chest and there is no crepitus going on there?
You still have a bruised lung or liver.
Or a whole lot, the same amount of energy that happened to an adult is the same thing that happened to the child, right? So they may not have crepitus because their ribs are not fully formed and still have the same amount of force. So high degree of suspicion just based on the mechanism alone. Especially common in the old folks, 5-fold increase mortality rate when 3 or more fractures, 4-fold increase of pneumonia, okay? So to no one's surprise, the idea in terms of somebody ends up with a rib fracture, especially the old guys, old gals, the idea they end up in an ICU based on pneumonia, okay? That is part of what we're talking about with pulmonary disease. Most commonly fractured ribs are the 3rd through the 8th ribs, okay? Fractures of 10 to 12 ribs can cause damage to underlying abdominal solid organs. So the idea that we have the rib cage that comes down through the side ends up bruising this, and you're going to end up hitting the liver along the way. On the opposite side, we're talking about the spleen. On the posterior side, we're talking about the kidneys.
CPR when we're doing damage? Is it like a clean break, or if we're just getting like partial fractures?
Typically we're talking about the elderly, is that?
Yeah.
So typically, it's a clean break.
Can you go back one slide?
Mm-hmm.
One word.
So fractures of the first and second first and second require high force. So we're talking about this area right up in here. We're talking about a huge amount of energy that has to take place in order to fracture this. So when you have somebody, somebody with an issue as far as the shoulder based on this right here, you have to be thinking about the possibility of a rib that's underneath all that as well. Frequently, you may end up injuring the aorta or bronchi. May injure the subclavian artery or vein. Where does that run? So, right underneath, right here, right across here, okay? So the idea that all you have to do is take a pretty good shot to the ribs, and you can end up having damage in terms of subclavian vein or artery along the way. Results in pneumothorax or hemothorax. And tell me about atelectasis. What's that about again? So collapsed lung, but not in terms of pneumothorax. Collapsed lung in terms of alveoli not being well ventilated. Flail chest. You're all looking tired. Stand up. Get some blood into those legs.
Oh, Z. Like the sugar lately? Wow, John, I'm impressed. Yo to everyone.
All right, somebody get me started with flailed chest. You've been telling me for 6 weeks now about flailed chest. What is it? What's the big deal? Who cares?
With the other side of the chest.
Say again?
The discordance with the opposite side of the chest.
Okay, so how do we define it? Yeah, but how do we define a flailed chest?
3 or more consecutive ribs and two.
What was that?
3 or more ribs broken in 2 places.
Did you all hear that? Okay, so we have a number of different ribs on one side that's broken in a number of different places. How are you going to know that? You may not know it. If there's not a paradoxical movement, you may not know that. But the idea that if you're running your hands, you're palpating along the chest, and you get like the sponginess throughout, especially on the lateral side, it's most common on the lateral side. The idea that if you start feeling the sponginess from here to here, you should be suspicious in terms of the possibility of a flailed chest along the way. Yes? And then obviously about not symmetrical chest rise is going to be a big deal. What's the real problem with these patients? It's not the flailed chest, guys. What's the real problem with them?
Trauma, the impact that it took to break the
There you go. The idea in terms of trauma underneath all that. We'll call it a pulmonary contusion. Pulmonary contusion is something we're going to camp on here in a couple minutes. So not only is the lung excursion not able to do its thing, but you have a pneumothorax, and then you have a pulmonary contusion that's underneath all that. That's the real problem with flailed chest. Mortality is increased with advanced age, 7 or more rib fractures, and yes, you can have a complete area of one side that's fractured, depending on the trauma. 3 or more associated injuries, shock or head injuries are all possibilities in terms of making this thing worse.
They fix these. They have to go and search.
You know what? It depends on the severity of it, Jason. If you get somebody that is have like this seminal ribs type of thing, they'll go in and they will wire that. But these days they kind of got away from doing that just automatically, to the point that they allow the ribs to try to heal themselves. So again, changing landscape.
Do they put like a, something around them or
So
something like
we're
that?
gonna answer that, or actually you all are gonna tell me about that here in a couple of minutes, okay? So hang on to that.
Okay.
Again, look at the mortality rate. We're talking about a third of these patients end up dying secondary to some broken ribs. Big deal. And again, this is kind of the common area that we're talking about. So back to thick. Remember the thick that you're trying hard to forget? Back to thick. The idea in terms of pulmonary mismatch across the chest is the real issue here. Okay? The idea that blood can get in and cross that barrier and get to the alveoli does not work so well when the chest is messed up like this. Okay? That puts it into play for you. But in addition to that, we have somebody with pulmonary contusion. We have somebody with interthoracic injury. We have somebody with a diaphragm that's not working well. We then start putting in the paradoxical movement of the chest, and then pain. Has anybody seen somebody with a flare chest? So, do you remember what the patient was likely?
It was a general train wreck, it was just one of many issues.
So it was just one of many, right? And that's kind of the point. That's kind of back to this right here. That usually it's not by itself, right? But the patient I remember is that there was the first time that I ever seen paradoxical type movement. It was pretty impressive. To that as well, the idea in terms of them being able to breathe all by themselves is almost non-existent. So you stepping in and doing positive pulmonary type ventilation will be one of your necessities for the flail chest.
That's because of the, you can't make a good seal, right? Because the slides are now because of the pressure, atmospheric
Right.
pressure deal.
Right.
Probably feel pain too.
Yep.
Yeah.
The person that we had, that's definitely true, but he also, we couldn't lay him down to put any kind of breather.
And why would that be?
Just more pressure.
Part of it is pressure, but part of it is fluids. So remember that they can be bleeding into the lungs as well. So by laying them down, you're only making this puppy worse.
What do you mean during positive pressure?
Positive pressure. So remember a couple of weeks ago we talked about you and I as we are sitting here right now, we're doing negative pressure. That is our diaphragm pulling down and out, and atmospheric pressure is doing its thing. When you choose to intubate somebody, what you're doing is you're switching from that negative pressure and you're forcing air into the lungs. Okay, that's called positive pressure.
So you're not just talking about hyperventilating?
No.
DVM?
No.
Okay.
We're just talking in general that you change the way we're ventilating our patient. That's the difference. So with that, as you might imagine, anytime that you have paradoxical movement, the idea that you're going to have an end tidal that's going to be out of ceiling somewhere. So getting end tidal of these patients early on is one of your big deals. Ventilation is one of your big deals. So how aggressive do you want to be in terms of putting a dressing over this or securing it some way? Or because we've come full circle in terms of this entire thing. I gotta tell you, 40 years, all the changes that have taken place in terms of flail chest has changed. So what's the current thinking?
Stop it, try to stop it from coming out.
That's what we would like to believe. So no,
Fair enough.
Open dressing on it, really?
that's what some would believe, but no.
Wasn't it a test question? Or a different test? I didn't ask that.
So what?
I was definitely interested in going
We can do that as well.
Nothing.
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 Nothing. So it used to be, let me tell you all the different places where we've come from. We've come from putting a sandbag on them, on that side, to secure it.
That's what the book says.
We have come from putting a pillow on them, on that side. We've come from, I think your book talks about securing or pushing rolling them over onto that side, to split that area. We've come from that. The reality is we're doing nothing. Nothing. So from our standpoint, the idea that they've got non-symmetrical chest rise is something a surgeon's going to fix. You and I are not going to have a huge effect about that.
So National Registry.
National Registry will not ask that question these days. Take that one off your list, Charlie.
So do you think we should intubate them? Or no?
I think that if everything we're talking about here, we have somebody that's in huge respiratory distress, I'm certainly going to be thinking about that.
But not just at the assessment?
No, not all by itself. I got a flail chest, intubate me, no, it doesn't work quite that way. But you have to know, John, the idea that with a flail chest, the signs and symptoms of respiratory distress is going to be big time. almost every patient that I've seen with this has been big time.
So if we do end up intubating them and everything, and like Sarah said about laying the patient down, I know we're RSIing them, but would we keep them at an angle?
I would-
Because of the fluid, because of.
Sure, I would keep them at that 20, about that 20-degree angle, so I would have their head up, but remember, if these guys got a flailed chest, they're gonna be on a backboard, okay? So
Right.
taking that backboard, just kind of tipping up the head of it is what we're talking about,
Okay.
okay? Let's see if this works. Non-symmetrical chest rise.
Why is he on the backboard? Cause of the trauma of it, the mechanism of injury? Okay.
More importantly, when their garbage can come in space.
It's recycling.
It's the only thing they can find, they
They're
wanna take a video
recycling.
now.
Oh, and put this on Facebook, you gotta get a garbage can?
You see the problem with this area right here? So there's a good possibility that, let me find the chest somewhere. There's a good possibility that the flailed chest is this whole area right in here. Okay, it's probably just more than the 3 ribs, it's in this entire spot of this part of it. So again, you keep hearing about contusion of lungs, contusion of lungs, contusion of lungs. I'm telling you, it's a big thing. We'll get there in the thing all by itself. So it also has decreased lung compliance. Why is that significant for you all? Yep, what about ventilation? It's harder to bag these patients. So if it's harder to bag these patients and they're already having issues in terms of this, do you think that you can create that much worse effect by pneumothorax as possible? By overventilating, by being too aggressive along the way? Absolutely. That's why it's kind of a big deal. They can be bleeding within the lung itself. Again, we kind of been talking about that rarely is it ever just a flailed chest all by itself. There's other things that kind of go along with that. You may not even have an idea as to what they're all about, but they're there. So airway and breathing control, if using a bag valve mask, consider attaching a PEEP valve, okay? Give me 2 seconds. I'll show you what I'm talking about.